Everyone, thank you so much for joining us today. We're going to be talking about training health system leaders through a longitudinal project-based resident track and care transformation. My name is Chris Moriades, and I'm joined by my team here, Emily Venus, Greg Wallingford, and Mustafa Abdul Mohit. You'll be hearing from each of them. We're all from Dell Medical School at UT Austin. And I think as we each present, we'll go ahead and share our roles. But we're really excited to share with you today live, and those of you seeing this recorded after the session, about our experience building this program over the last 6+ years here, actually 7+ years here at Dell Med. As many of you are aware, there is a growing mandate to include health system science within graduate medical education, that we need the skills, the attitudes, the knowledge in order to deliver on that third pillar of medical education. But few examples exist. You know, we're being told we need to do this, but there are very few places that have tried to implement real experiences in health system science. What you have in front of you, you may be familiar with. This is the framework that's been put forth as far as all of the domains, linking domains that create the world of health system science. And so during this lunch hour, we're going to take some time to describe our experience developing a program that was built in order to share across our medical school these principles of health system science. One of the challenges, at least that I thought about here at Dell Med, was that for those of you that don't know, we were a new med school just over 7 years ago. So in 2016, opened with this clear mission around value-based healthcare, population health. And so we had a blank slate as far as the med school curricula, and we were developing curricula around this in the undergraduate medical education world. But in order to make that real, we needed to bridge that what we were teaching in the classroom to what we were actually doing within the clinical environment. So we need, as Vinny Aurora and colleagues have described, we need bridging leaders who help align the educational and clinical priorities, goals, and opportunities. And then we need to create system change that reinforce this alignment. In other words, we need to create real experiences during clinical training for our clinical trainees to experience what it means to lead care transformation, what it means to put all of this into practice. And so that was essentially, the design behind our curriculum, which I'm going to let my colleague Emily Venus describe for you all, around advancing care transformation, and then specifically around the distinction program component of that.
Hi, everyone. I am Emily Venus, Assistant Dean of GME here at Dell Med. Part of our institutional mission here at the medical school is to educate leaders who will transform healthcare, focus on person-centered care that rewards value, and improve the health in our community. And these are really inspirational and lofty goals, and it can sometimes feel overwhelming to think about how to turn these into a reality, particularly in the GME space. Residents are so often just consumed with getting through their day-to-day. So when we were challenged to create educational opportunities that align to the mission, we wanted to be really thoughtful on how we would build on their training in a meaningful way, rather than create an added burden to their already hectic schedule. So the result of a lot of ideation and logistical problem solving was the Advancing Care Transformation Curriculum, or ACT. ACT goes beyond traditional clinical training and focuses on the broader healthcare system. We felt that by allowing trainees the time to gain a deeper understanding of the system and their role within it, they would be able to make more informed decisions, effectively problem solve, effectively lead, and ultimately enhance the care that they provide to their individual patients. So we use the health system science framework that Dr. Moriades just discussed as a guide for our design, which consists of 2 separate levels or tiers: the foundation in care transformation and the distinction in care transformation. Next slide. The foundation in care transformation emphasizes the core elements of health system science. All residents and fellows at their option participate in a grand round style learning series that includes topics like introduction to health system science, distributed leadership, health system scholarship, informatics, policy, economics, equity. We host these sessions once a month at noon for about an hour. They take place virtually. That helps us optimize attendance, but we also record the sessions for future viewing and then distribute them upon request. So the foundation is a pretty straightforward Grand Round series. Next slide. The second tier, which is really more of the focus here today, is the Distinction in Care Transformation, or what we call the Distinction Track. It's available to residents or fellows who want a deeper dive into health system science. So it's a 2-year experience open to selected residents and fellows from any specialty. Program directors select their participating trainees, and they do so based on a number of factors, including their interest in health system science, whether or not they're in good standing, and their potential for leadership. Once they're selected, trainees from all specialties begin the distinction track together and progress through it as a cohort. The curriculum in this track includes coursework that spans the entire 2 years, as well as a required health system scholarly project. So the cohort is actually excused from their clinical responsibilities to attend several in-person workshops. So they're immersed in active learning as a group for up to a week at a time outside their regular clinical work. So we pull them for workshops 2 times during the first year of the 2 years for a full week. And then we sprinkle some of those workshops and other project update meetings throughout the remainder of their time in the track. The workshop series is focused primarily on interprofessional teamwork, so working with peers from social work, pharmacy, and nursing, leadership, communication, so things like crucial conversations, maybe some conflict resolution, quality improvement, we focus on methods and tools, advocacy, and design thinking, which actually is not a component of health system science, but just a resource that we are fortunate enough to have access to and incorporate into this track, which allows our participants to learn how to become creative problem solvers. So these sessions are designed to prepare them as health systems leaders, but also to provide a foundation of knowledge and skills that they then apply to their projects. Next slide. So projects for the distinction track are selected by the participants and approved by the ACT Curriculum Oversight Committee, which is a team of institutional leaders with expertise across the content areas. We oversee the curriculum's implementation, and we also serve as core faculty for the track. Projects are approved based on feasibility and area of interest, which can vary depending on specialty or community need or even clinical context. Trainees can design their projects around central institutional initiatives, so you can do that in conjunction with the medical school or the hospital system. They're also permitted to work with other colleges across the UT campus. They can work as individuals or in multidisciplinary teams to create mostly value-based QI initiatives, some research studies, but they're also permitted to develop community-based design projects or even health technology if they're so inclined. Each project is mentored by a faculty member from the participants' core training program with additional support coming from the Curriculum Oversight Committee. Now, once they've completed their coursework and their projects, participants present their scholarly work at the Distinction in Care Transformation Forum. They also receive recognition at their graduation ceremony and a special diploma that they can hang on the wall next to their primary training diploma. So that was a brief overview of the ACT curriculum. I'm going to turn it over to Greg Wallingford, and he's going to share more about the experience of our internal medicine residents and fellows.
Thanks, Chris and Emily. So I kind of want to jump into some of my thoughts having participated in the distinction track. I was very lucky to be one of the cohorts. I was a fellow, so I was actually, I think, probably one of the first fellows joining the distinction track. I was also switching careers from emergency medicine to palliative care. So I had no community here at Dell, and moving across the country. I was coming from Philadelphia. And so I mean, in short form, I had done something like this in emergency medicine. I had participated in something like this as an attending. And then I came to Dell, and I was actually really pleasantly surprised with some of the features of the distinction track. And I think things that I didn't see at places I had been previously. So this picture of coffee is my version of bolus and drip, which I think is an important feature of our distinction track. And what I mean by that is that the distinction track here has dedicated 2-week sessions, one of which is that curriculum that Emily just talked about, and another of which is basically unstructured time to work on the project. But really what that does is, at least in my experience, get you really rooted in this mindset of being part of a community of people who are bridging that gap, like Chris said. And so you're like with this group who's selected to be part of the distinction track and getting excited by the pediatric residence ideas that you heard about and the OB-GYN residence ideas that you heard about, and sitting there in a classroom with them in small groups. And so I think it's community building for one. Certainly for me, it was something that made me feel part of DelMed as opposed to a participant in a distinction track. And then the second week being unstructured allows you to like really have structured thinking time, which I think is also a big barrier, at least in my own experience, is that sure, you might have a block of time here and a block of time there, but that's really hard when you're thinking about the vague problem of like, what do I want to take on in this health system? Like, do I want to take on the ED admissions or discharges, or maybe something smaller like replacing a medication to comply better with guidelines, or improving, discharge follow-up for a particular patient population? Then you have to figure out, mentor, who's going to be the person who I'm going to go to for advice about like me and how I'm developing, like finding a coach. How am I going to do it, et cetera, et cetera. So what I found was that first week of these two-week blocks was like curricular, exciting, gets you really engaged. The second week was like deep thinking and meeting with people. And those are the boluses I'm talking about, one in the fall, one in the spring. And then throughout our internal medicine distinction track, we also have 4 quarterly meetups, which I think serve as this informal, I'll call it positive peer pressure. But like if I show up with Mustafa, let's say, and Mustafa and I are both working on projects that I have nothing to update on, I just feel this kind of desire to keep up with him, and not in a way where or I feel bad or anything, but rather you're inspired by the people's progress around you. Secondly, I think it helps build a community of people who, are also passionate about this work, a community of people who's basically smaller and contiguous, at least throughout residency. And then I think the last part, which is fun for everyone, is like you get to have a beer and, go grab pizza at a cool place around Austin on the department. The picture up here in the upper right, these Lego blocks too, I think is a really cool part of the distinction track, which is that it's modular. So the curriculum is offered to everyone, the foundations curriculum we talked about, but how each department supports the residents is up to that department. I think that's important to mention because different departments probably have different resources, different expectations, different goals. And so you're basically providing the foundation through the foundations curriculum. But each department can say, I want to focus more on research, or I want to focus more on health transformation. Our department has been quite supportive, and we've had coaches and mentors. Broadly speaking, I'll say coaches focus a little bit more on the development of the person. So like the resident who's in the track. Mentors focus a little bit more on the project. So one's focused on the person, one's focused on the project, and both very much overlap. So the person's also focused on developing the person and the project. But you have different like mentors and coaches for each. And I think what that does is create some psychological safety around the fact that like, I don't know if, I'm still excited about this project might be a better question for a coach rather than going to the mentor of that project. And so I think I'm just pointing out here that having a mentor and a coach has been very helpful for our residents. Next slide. So like I mentioned, I came during a time where my career was transitioning, my life was transitioning from one city to another. And I came during COVID. Actually came during the first surge of COVID in Texas, which was kind of nuts. So I didn't know people at all. And so when I came to DelMed, this is actually one of my first like dipping my toe in the water type of things where I really started understanding how committed this institution was to health transformation. Um, I'd been in the, ER, so on the right-hand side here, resuscitating patients in the thick of all the scariness of COVID. And I was now sitting on this other side on the left, talking to patients and families, often at length in a situation where really there was so minimal in-person contact. And so just by chance, and I think in part because I was in the distinction track, I was asked, hey, you've been part of a lot of codes, but also a part of like talking to patients and families in distress. Do you think there's something that we should be doing here to support our trainees during a time when people and patients are dying at an unprecedented clip, but also at the beginning of the year when people are new here like you and don't have a chance to connect and build community before this hard thing happens? And so the intervention that I designed was called supportive debriefing or rapid supportive debriefing, which is really a structured debrief meant to support patients, well, really teams taking care of really sick patients, and then patients and families if they want to join it after something really stressful happens. We started just with codes. And so it's really a nice blend of my palliative care new experience with my ER background. But I think like one of the really cool parts of it was that because I'm part of this community, because I'm getting mentored by Chris, who's one of my mentors for this project, I was plugged in a way that was like, oh, I then met with the chief of hospital medicine who was like, yes, we should absolutely do this. And then there was someone who helped me with the qualitative research design. All of this through this central distinction track. So I got connected with a bunch of people, but then I was also part of a community. So like I showed up to the distinction track, and even though it was via Zoom, there are like 10 or 15 people that I'm seeing on a daily basis now in the hospital that could be allies, that could help with implementation. And I think both aspects of that were really critical to making this intervention take hold. So next slide. So here's just some of the results. I think I don't want to focus too much on the results. This isn't about me or my project, but rather the fact that I was able to not only be asked to do something, be connected with the resources, be connected with other mentors who have research expertise, find a community, but then have the follow through and follow up with this institution that was afforded through relationships I built through the distinction track. So we've been able to basically show that when something hard happens and you do this type of debrief, the way you feel is in that orange bar. And when something hard happens and you don't do this type of debrief, how you feel is in this gray bar. I think the narrative here really is that when hard things happen and we don't debrief them in a way that supports teams and people feel very ambivalent about what just happened. They feel in that gray bar. They feel ambivalent about connection with meaning and work, connection with patients, connection with the clinical team, and uncertain about asking members of the team for help. After the debrief, what people tell us is that they feel more connected to meaning and work with patients, with clinical team, and more comfortable asking for help. And so, as a result of being basically part of this track and this community, I've been able to do a lot of cool stuff and present this in a couple of different places, but really I'm indebted to this track for allowing me to do this work. I certainly couldn't have done it without it. Next slide. I think I'm turning over to Mustafa here.
Yeah, and thank you, Greg, for sharing that experience. Hello, everyone. I'm Mustafa Heath, currently the Hospital Medicine Fellow here at Dell Medical School, and also an alumnus of the Distinction in Care Transformation Program. Greg is bringing back some memories for me. I remember experiencing that culture shift in time going to residency as we started doing more debriefs across our teams. And I kind of saw firsthand how it positively impacted both our faculty and our learners. And ultimately, it's the promise of these experiences that really brought me to Dell for my training. As a medical student exploring options for residency, I knew I wanted to be at a place that was looking towards building a better future for healthcare. I had the opportunity to take some basic introductory health system science classes while in medical school, and it really opened my eyes to the severe need we have for physicians, especially newer physicians, to be more involved in the systems we operate in. I wanted my training to help me become more than just a clinical provider. I wanted to better understand this massive behemoth that is our healthcare system and work on meaningful solutions that enhance the experience of care delivery. I also wanted that to be paired with meaningful impact on the community around me and to hopefully manifest something tangible, especially for those who most need it. So here at Dell and the broader University of Texas at Austin campus, I was able to embrace this intersectionality of medicine, the human experience. I created this kind of crazy Venn diagram here on the right-hand side. We'll go through that a little bit later. But I just wanted to highlight that throughout my time in the distinction program, I was able to develop a unique skill set that blended learning about the human experience, incorporating novel technologies, and utilizing some fundamental quality improvement techniques. And I wanted to, like Greg, showcase a few examples of this work. So can we go on to the next slide, please? As a new physician, for me, one of my first goals was, in addition to building a clinical foundation as a resident, was to better characterize this healthcare ecosystem I was operating in. And so I was fortunate enough to have an opportunity to work with the Design Institute for Health, which was an interdisciplinary group here at UT Austin that utilized human-centered design in healthcare. So briefly, kind of put a picture of the double diamond philosophy of design thinking on the bottom left-hand corner there. Human-centered design and its processes are basically an iterative problem-solving methodology that really focuses on the needs of the end users and brings their needs, motivation, pain points to the forefront of a product or service. And ultimately, that allows us to design a better experience and ultimately develop more effective systems. So we utilize this approach and this mindset to look at a very hotly contested topic across healthcare, transitions of care, particularly between our inpatient setting and outpatient settings. We use a combination of ethnographic research, survey data, user journeys, empathy mapping, and we were able to develop a pretty detailed transition map that documented in pretty granular detail, essentially, the various interactions and obstacles across the transitions process. We were able to workshop this with stakeholders all across the spectrum, and ultimately, we were able to share these insights with various actionable parties and identify opportunities for improvement. On the flip side of this, as a resident, I was able to work on endeavors involving PCP communication, discharge summary education, and workflow standardization across the residency. So through this journey with the Design Institute, I wanted to highlight that as a resident coming into a medical system, I was exposed to a brand new perspective. And that's really important for a lot of us who kind of come into residency or into medical school and are just taught, this is the way how it is. You just got to do it this way. This is our system. And I feel that's really a disservice for our burgeoning physicians because those new perspectives are required for us to develop unique insights that are oftentimes overlooked in our day-to-day operations. By taking a step back through the distinctions program and honing my skills of empathy, I was able to generate a nuanced understanding of the system I was operating in with the goal of pushing the healthcare needle forward. And this mindset was really good exercise for me. And it played very nicely with my next endeavor, which was using this understanding to build better tools. So next slide, please. All right, so I had this right mindset. I had a good understanding of the system. And now I want to leverage that knowledge to develop a tool to best accomplish or best bridge some of the gaps that we've identified. So given my interest in systems and technology, I was fortunate enough to be connected with another interdisciplinary group on UT campus working on, this is a mouthful, patient health identity management based in blockchain. And we're calling this MediLinker. And essentially, blockchain famous in lay media for its use in cryptocurrencies, but it has a wide array of uses all across different industries. And in healthcare, it has the potential to help with interoperability. And as you all know, this lack of interoperability in healthcare accounts for a significant amount of waste and frustration for providers, especially for our patient population when they're jumping across different health systems, different EMRs, and have fragmented siloed care. So I used some of my experience with the Design Institute to give me a realistic perspective from which I could help the MediLinker team develop this blockchain-based application that can help bridge some of the gaps when we're jumping through these different silos. So this is a group that had folks from many different backgrounds, and we wanted to create a solution that focused on security while also promoting patient equity and autonomy. And I'll spare you some of the technical details, but ultimately we were able to run a controlled pilot study that allowed us to share secure documented information stored in the blockchain across various test sites that mimicked clinics, hospitals, and research institutions. And so as a patient, you could show up to one place, submit all your information, and know that you can take that information to other places. This pilot study was very promising because of the potential they held, but also valuable to me as a newer physician because it showed me what the future of healthcare delivery could look like, 20, 30 years in the future. Next slide, please. And so these two projects are among a handful of unique and insightful opportunities I had to push the healthcare needle forward while developing my skill set as a physician in residency. And Chris, if you could press it forward one more time, I think there's an animation that plays there. There's a variety of different experiences, and I was so blessed. I'm going to echo Greg's comments here, really grateful for the program to have the opportunity to explore all these different facets across different disciplines. The distinction program provided me with the fundamental knowledge related to health system sciences and the protected time to explore interdisciplinary endeavors that intersected healthcare. And this is what I believe all physicians should have an opportunity to do in their residency, to expand beyond the limitations of just clinical mastery. The future of healthcare will definitely require us to help develop physicians who are thinking about the challenges of tomorrow and have the skills to creatively tackle any obstacles that may arise. And it's not just me that had a great time in this program. I think all of our residents have had great experiences, as I believe we'll share here just now. To the next slide.
Great, thank you guys. So we actually, I'm going to back up for a minute. We talked broadly about how this program works across the school and gave you some concrete examples of the type of projects that folks do. Just to be really clear, in internal medicine, since this is the AIM group, we have residents who traditionally had matched into the program. So we had a separate NRMP match for this, where people would match to come in, and during their intern year, we would have those get-togethers, as Greg described, and start to get to know them and tell them to pay attention to the system and see opportunities. And then during second year, they would go ahead and start the foundations curriculum, do the 1 week in the summer. And at that time, we would work on matching them with a mentor, with a project, and getting something within their area of interest. And then they work on their project during their second and third year. They each get to take up to 1 month of protected time during each of those years if they choose. And we do that as like a research month where they can really progress. But many of them work on their projects throughout. They can work on it during QI half days, during their ambulatory blocks. And then, as was mentioned, they present at the end. And so we've had, looking at our internal medicine graduates through the program, all of our distinction program residents who've participated, our primary care track residents also participate in the distinction program. And then, as Greg mentioned, we have had our palliative care and, as Mustafa mentioned, our hospital medicine fellows participate. Across all of those groups, we now have had 33 people graduate within internal medicine, having participated in the distinction program. And we're collecting what they do after that, or what were the outcomes or results of their projects, and then what are they doing moving on. So this actually is like a real draft form of the Excel spreadsheet we're working on, but we have essentially now started to collect that data. And we see that out of the 33 graduates, so far we've collected at least 19 invited national presentations about their projects, I'll mind you. So many of them presented nationally for other things, or they went to cardiology fellowship, but just looking at specifically their distinction project, 19 have presented nationally. At least 9 have published peer-reviewed journal articles during their training related to their projects. 16 of the graduates went on to do chief residency, 18 have so far gone on to fellowship, and 16 currently have a faculty appointment. So you can see that we are setting folks up for many different career paths. And so far, we're collecting some follow-up data, and 20 folks have responded out of the 33 to the survey. And so far, all of them have said that they're using the skills that they've picked up in the distinction program in their current roles. And again, that's diverse roles. Some of them are private hospitalists down by the border here in Texas, to chief residents, to ID fellows, cardiology fellows, to faculty members in primary care, hospital medicine, and elsewhere. So really pleased, and we're going to have, I think, all that data to share in our own peer-reviewed article that we hope to come out this year. So we're working on. Now, I want to make sure we have plenty of time at this point to answer questions that you might have about how the program works, or specifics. We can talk about anything. Feel free to use the chat box. I'm looking at it, but also please feel free to unmute and we can chat. And again, thank you for joining us, and thank you to those of you who are watching this recorded as well.
Hi, everyone. I'm Dr. Sabrina Tildon. I'm at the University of Miami. Just wanted to first thank the presenters as well as the graduates who have showcased their projects. It's fantastic. I'm interested in asking and learning a little bit more about what you do. I'm at the University of Miami in graduate medical education. I'm also now the Associate Chief Medical Officer. And so I can only imagine all the fantastic accomplishments that your graduates will have. We started a pathway called the Healthcare Administration Pathway here about 5 years ago. And I was really fascinated by the fact that you said that there are other disciplines other than internal medicine that are involved. And I was wondering if you could share a little bit about that, because we've had a lot of interest from others, but you know, we're in the brainstorming phase about how to actually accomplish that. So it would be great to learn from your experience.
Yeah, Emily, would you like to field that?
Sure. So, you know, first of all, it was a labor of love. It was not easy. And I'm just going to be very honest about that. One of the first things that we really wanted to think about was how we could get them together. Putting aside clinical responsibilities was key. They had to have protected time at the same time. So we really had to navigate a lot of logistical responsibilities. We had to get, buy-in from the program directors. We needed to look at board requirements to make sure we weren't pulling people out for, long so that it would extend their training. So we really had to think about those logistical obstacles first. And then once we were able to pull the schedules together and determine exactly when we were going to do this, we had all of our people on board. They got together and they were able to really, as I think Greg mentioned, listen and learn from each other and participate together in a space that they wouldn't necessarily normally communicate or collaborate. So, but it wasn't easy. It was getting the program directors on board, making sure that we weren't extending anybody's training, making sure all those logistical details were worked out.
And did you use this this recommendation from GME to create a sense of urgency to kind of get their buy-in, or did you feel it was more organic from their side coming to ask to integrate?
It was definitely mission aligned. So the mission and having the support of the dean and the DIO was key. And actually also the hospital administration as well. And one of the ways in the program that we didn't really discuss or cover that we try to include hospital administrators in the program is we set up a leadership shadowing experience. So each participant is paired with a person that is from the C-suite. It could be the CNO, it could be the chief quality officer, the chief medical officer, and they shadow them for a few days, up to them to determine the length. And they discuss their projects. And so they learn to get buy-in from different levels for their own projects.
Well, yeah, thank you. I'll add one thing about the motivation. I don't know if I should share this or what, but I'll tell you early on, this was really, the dean put this forth as like a recruiting tool. So, the residencies had existed here in Austin, mostly as community programs, but Dell Med School started in 2016. So we were a new med school, and we were now sponsoring these residency programs. And so the mission and vision of Dell Med School was very much out there as rethink everything. We're about care transformation. Here's what we're going to do. And so in order to recruit applicants who had not generally considered coming to Austin in the past, we prominently put forth this program. And I know in internal medicine, at least, I can't speak to all the programs, but I feel like that was one of the big motivations. And in fact, why we had a separate match, I know for a fact that at least in those first couple of years, there were some residents who really only came here at that time because they matched into the distinction program in care transformation. We have since, I'll tell you, gotten rid of that match. So now this year we're selecting during intern year, people are applying to join. So they're just matching into our categorical. But for the first 6 years, I think it was, I try to think it was 5 or 6 cohorts, but it was 5 to 6 years, we had that separate match and basically used it as a recruiting tool.
Thank you.
And I'll just add one other thing in terms of framing like the value of this to try to get the buy-in for a coordinated effort is I think there's certainly an argument that residents do great with it and residents have these phenomenal outcomes. I think the secondary benefit is that the faculty do too. Like it forces faculty to hear about cool projects and get excited. It forces faculty to think about projects when residents bring them up to them. And it kind of enables faculty in some way to continue engaging in more through someone else than they could alone. And so I think there's a faculty development, like secondary kind of like halo effect, if you want to call it that. So I think there's clear resident benefit, but I would also argue there's clear faculty benefit as well.
Hi, everyone. My name is Rahat Noor. I'm an associate program director at the University of Mississippi Medical Center in Jackson. And I am currently working with our GME, trying to roll out a health system science curriculum and collaborating with another institution simultaneously to do this. And I have so many questions. I think some of them, you guys talked about how you, it sounds like you basically had a track and people were coming into this track specifically. I had questions about, how do we roll this out in, because we don't have a separate track. So, we're rolling this out to all our residents and fellows. From the last count that I remember, we had about 13 people that have showed interest, and our GME hosts about 600, 700 trainees. It's a sizable program, What was your experience like? How many of the residents actually sign up at your places? I was also trying to think of, you guys talked about dedicated time for the learners, but is there dedicated time for the faculty? How do you account for that? I mean, with all the burdens that faculty have, how do you account for that? And I guess my third question would be, while the projects are going on, how do you track the progress? I know you guys talked about the end result, and Chris, you showed a great slide at the end, and it's fantastic to see, but while the program is going on, how do you keep them on a timeline? How do you track the progress? So those are some of the immediate questions.
Wonderful. I'll get started, but please, team, jump in and help with Rahat's question. Nice to see you too. I recognize you, I think, from Twitter, which is cool.
Yes, and the Leadership Academy that you ran. This was, I think, 2018 we met. 2018, 2019, maybe, right before, the SHM Leadership Academy. So
yeah, that was a lifetime ago, before times, but wonderful. Thank you. So your first question, I think, was about how many residents are interested. Now, I will tell you, we, again, being new, being small, we started this out quite small. So we kept it that first year in internal medicine, only 3 residents were matched into the program for internal medicine. Now, as was mentioned that year, I think there were 3 pediatric residents. There was 1 women's health, 1 surgery, And
There were 8 total the first year.
yeah, okay.
Only 8. So that was like what I would call a pilot year.
And that was so that we had the bandwidth to, one, get them that protected time and get some projects and all that. We've grown to, but still only grown to 5 internal medicine residents at any one year in the distinction program, plus the 4 primary care residents who participate in it, and then plus our fellows. But we're still kind of, capping it. Now, our programs, again, are much smaller. We have 22, is that right, Mustafa, internal medicine residents a year. So 5 is still like, almost a quarter. Actually, when you do them plus primary care, I mean, it's a significant group. But we are kind of artificially capping it. Now, what we have done, as was mentioned by Emily, was we started to take some of the content from the health system science foundational content and put it into our all GME grand round. So some of the stuff that only exists in the distinction program the first 2 years, as far as curriculum, we now deliver to everybody via our all GME grand rounds. I mean, to be honest, what's the pickup of that? I mean, officially, all of them have to go, but they don't. I don't know, so I think there's still like, the people who are very interested in this are a smaller subset, but I don't know. I don't know. I mean, we certainly filled our spots every year. It'll be interesting to see this year how many interns apply, but I'm going to bet that we get more than the 5 spots we're making available of our intern class who's going to apply for this, just based on what we're hearing in the hallways. So I think that's, about the how many people are really interested, engaged. And I would recommend to you have some sort of version of that where you're giving some of the content to everybody. I mean, if you're going to bring in a speaker or faculty member who's going to talk about some foundational component of health system science, I would suggest you don't want to share that with 13 out of 600 GME learners and get a forum for them around that, but then have kind of the high fidelity program, something that's a little extra for those who are really engaged. As far as faculty dedicated time, that's been a bit of a challenge. So there's the central core, which Emily Venus runs and which was described, which is at the school level, but then each department has some ownership over what happens in their department. So we're fortunate in internal medicine, essentially because I'm assistant dean for healthcare value here. I had some resources essentially that I can invest in the program to protect a little bit of faculty time, although very, very little actually. I mean, some of Greg's time to coach, some of my own time. But we don't provide funding, say, for the project mentors. Most of these folks are doing it because it's part of their academic, role, and they're leading a project with a resident. That's part of what they do in their time, but they're not getting extra, protected time to participate in the curriculum or in the program, I should say.
I think the carrot there is the in addition to working on a project that you're really interested in and collaborating with a resident, it's also something that you can put in your portfolio.
Yeah, I mean, these residents are, a lot of them, not all of them, but a lot of them are rock stars, and they're going to be doing great work. And so for the faculty, it's, again, they're getting these presentations and abstracts and papers on their CVs too. So it really is a benefit to them. And we have certain faculty, like our clinician investigators. We've got a nephrologist who does disparities in care around nephrology. She basically takes a distinction resident every year, which is really nice. So we've kind of created, in a way, these paths for people. It's like, you want to work on disparities or you want to go into nephrology, you should work with Tessa Novick. And so we've created kind of these portfolios of projects that people plug into. We can talk about how we track project process, but let me pause and see if Greg, Mustafa, Emily, you want to add anything about the interest or the protected time.
You got it.
Okay, so tracking project process, again, I think there's something at the department level. Like, essentially, Greg and I now check in during those quarterly meetings. It's a little bit informal, honestly. We kind of keep just like a mental list, which again we can do because it's like 5 residents a year. And so we check in with them, but at the central level, and Emily, you can talk more to this, but they turn in updates. So maybe like twice a year or so, they turn in kind of their project, formally turn in their project updates to y'all.
Mm-hmm. So we, from the GME office, request project updates. making sure everyone's on track. We also hold what we call works in progress meetings. So the committee members schedule time, and the participants choose a slot. They come, they tell us where they are in their project for about 10 minutes. We make sure they're on course, on track. We offer additional resources if they need it. We give them feedback. And so we do that a couple of times a year as well. About the midpoint, we ask them to put together a works in progress poster, something that's sort of like an abstract without the results. And we do that also just to make sure that they're formally staying in line, staying on track. They don't necessarily present it, but it is there for them to present and fill in the results if they want to submit it to a national meeting once their project is completed.
I would say one thing too that we could probably maybe even do a little more of, at least in the IM track, is celebrating the progress and products of the people who are like doing stuff and creating awesome change in the hospital and or manuscripts and or whatever. Because I think, again, it's like this mechanism of positive peer pressure. It's not like you're putting other people down, but you're rather like, oh my gosh, like Chris is doing this awesome thing. I need to get on mine. It almost makes people excited in a positive way. And so we've done some of that. And we've also done some like peer mentoring where the outgoing third years will present like their 5-minute version of lessons learned that they wish they had known when they were a first year. But it's coming from like, like the wise elders who are really close near peers. And so I think it rings true in a way that like, if I gave the same message, it may not. And so I think it also like gets people talking about what they did in a positive way of like, you're an expert, tell us about this stuff. And they'll tell you then barriers they ran into, but also great successes they had. And I think that, again, that's just a cycle of like getting people excited and motivated that's coming from their peers. So we try to activate peers a lot in the way that we, quote, track progress or check in or promote some of the work that's done.
Ask a question about the please forget, I'm very upset that I've missed all of your slides. Sorry. We're having board again today in the emergency department. So what are you finding that you need to have almost a shadow mentor for the residents who work with the C-suite execs? Because I worry about, I'm going to speak for my place, that they would be very enthusiastic to meet with, to work with residents, but may not be the same type of project mentor as one of your clinician investigators. And does that end up taking more time? And what kinds of projects does that, and if I'm curious what kind of projects they work on with those execs, and if it's in the slides, tell me to look. I will do that.
No, I think, again, good to see you. We always have boarders in our emergency room. I know exactly what you mean. So I think a couple of things. One is what we were describing was actually just leadership shadowing. So they don't do projects with the C-suite. It's part of that second foundation week that they do, which now happens to be in January of their second year. They have that 1 week, and Emily and team pairs them with a leader that then they go and follow. Usually, you said a couple of days. Our residents, I think, usually follow for like a day, but it might be there might be they get an opportunity to follow for a couple of days, just to kind of like see what a day in the life of the CMO is. Now, we did have a resident this past year work with our CMO because her career ambitions is to be in the C-suite, and so she worked with the CMO, and her project was she looked at like discharge pharmacy reconciliation or something, and it was great. But if you ask her, she felt like what she got out of the program was actually just that our CMO invited her to like meetings, and she went, and she kind of just got this experience that was very valuable to her outside of doing the distinct project, which does bring up one point, and this is again maybe a function of our scale, because fairly small, like that's, and we've taken advantage of that. I felt like it's been important for my residents to create kind of somewhat bespoke experiences for them. So there's the whole core, which we presented, but really like our answer to most things are pretty flexible about it. It's like, we want you to do something that's meaningful to you. And the project should be meaningful. It shouldn't be like a filling in an Excel spreadsheet, like research project. This has to actually improve like care for somebody in Austin. But we want the experience to be meaningful. So if hanging out with the CMO is what's going to be most meaningful to you, let's make that happen. You know, if working with the IT researchers and leaders and doing a blockchain thing that I don't understand is most meaningful to you, like Mustafa, let's make that happen. And so we were very, I think, open as to what that looks like, as long as it fits within kind of the realm of, yes, this is a real experience that is giving you skills towards what you want to do in the future, and it has at least the potential to improve care for somebody. It's not some sort of academic exercise.
I think, Chris, you bring up a good point in the context of this question. In that, I think also, Greg, you may have mentioned it, the network of coaches and mentors is important for the trainees, particularly as I was going through the program. I may have had a primary project mentor, but I also had other coaches who are asking me, hey, did you ask your mentor about this? Hey, did you explore this option? And that network really helped enrich the experiences I was exposed to. And ultimately, it helps grow your own kind of workplace knowledge about systems. And so I think a fundamental aspect of programs like this is that network of coaches, mentors, et cetera, that we can develop. And having that system set out will really help your trainees navigate through the process with, a semblance of structure.
Along that same line that Mustafa was just raising, do you all have a train the trainer? Do you train your coaches and your mentors? And if so, what does that look like? Because sometimes you have enthusiasm that's up here, but skill set is here, and it's variable, right? So not saying everyone has to be at the same level, but wondering how you approach that.
Go ahead, Greg.
Oh, well, I was actually going to say Chris might be able to speak a little bit better to this, but I think as a result of being a smaller and newer institution, I think there's a vantage point that we have into our faculty that's probably a little bit easier to manage, in sense of like, we know most people in the hospital and most people and well enough to kind of point people in the right direction of people that we know have been good mentors in the past. I think it's also the value of having a coach is that, if the resident goes on and the experience isn't what they were hoping for, or they're not getting the level of mentorship that they want, the coach can step in and be the advocate for them to either meet with the faculty or to help redirect the project or reconfigure it in such a way that like maybe it doesn't make sense to have that mentor anymore. But it takes some of the pressure off the resident to be the one to pick the mentor, stick with the mentor, keep that mentor relationship open, because the coach can always step in and say, hey, so-and-so was really looking for a C-suite type experience because that's what she really wants to do. It seems like this is going a little bit different direction. Is there a way we can reconfigure it or potentially, redeploy the project? That's just like an example I totally made up out of thin air. But I think the coach plays an important role in that, so that you don't get stuck with a bad mentor and then the whole experience then is colored by this bad mentorship experience.
Yeah. In the very first year or two, we did take advantage. Society of Hospital Medicine had their Quality Safety Educator Academy, their QC, in Austin. And so we invested in having like 10 of our faculty go to that QC that year here, which was, that was a good chunk of money. But again, it was like a lot cheaper than starting a whole train the trainer program. So that was one investment we made, like, back in 2017, I think it was. But as Greg said, a lot of it is we kind of know who the mentors are. Now we have intervened. I can think of one example, share, where like a resident kind of told us they really weren't getting what they needed from their mentor. And so we had we asked to meet with the resident and mentor in the, like, hey, let's have a check-in. And we kind of like coached the resident in front of the mentor, anyway, hopefully she doesn't see this and put this together, but we did some Jedi mind trick stuff, I feel like, where we kind of did the coaching in front of the mentor to try to come up with a plan and get them on track. And I can think of one example where we did that. All right. Well, this is great. We had hoped that this would be mostly a discussion. So I'm glad, we were able to finish early and have this discussion. We've got 5 minutes left. Any other last questions that you guys want to cover?
I did have a quick question. The Design Institute for Health that you all partner with, what does that sit under, just from like a logistics standpoint? Is that under the School of Medicine? Is that under the health system? Is that your like a separate entity that then you consult?
Yeah, I have sad news about that. So the Design Institute for Health was under the med school. Our inaugural dean, Clay Johnston, funded and started that. It was a partnership with Dell Med School and the College of Fine Arts on the UT campus. But within the last year or two, unfortunately, the Design Institute has closed up shop. So there's still is it a master's in design?
There's a Master of Arts in Healthcare Design. And through that program, we're still able to offer design thinking workshops and some consultation.
Yeah, and so we have a faculty member in design who teaches and works with folks, but the Design Institute for Health was a cool opportunity that we had here at Del Med that unfortunately we no longer have.
Change is constant, right? So that's what we're teaching. Thank you for being open about that. I appreciate it.
Great. Are you posting these for the delinquents of us who missed all the meat of your talk?
Yeah, so this will be sent out to everybody who registered after the fact. And then I'm told also once all of these webinars are done, Sheila and team at AIM are going to have it available for AIM members to see later. But the short answer is yes, this will be sent out to everybody who registered for this talk.
Thank you.